Hi, my name is Lyle Murphy. I'm the founder of the Alternative to Med Center, and after 18 years of doing this on a residential population, I must. If you're watching this video about Cymbalta, it's probably because you were one of the near roadkills of this particular medication. This medication not for everybody, but for certain people, have this boomerang that no matter how you throw it, it always hits you right in the head, and it's kind of discouraging. It's very unlike other medications in a certain way, and I think as we answer through these questions, maybe we'll get into that, and if not, then I'll do some free flow on what I think of this medication. First question, what is Cymbalta prescribed for? Many of you might think it's prescribed for intentionally trying to kill someone, but as the pharmaceutical, the class of diagnosis that are usually prescribed this according to the DSM-5 are for major depressive disorder, for generalized anxiety disorder. I don't remember if it's on label or off label for fibromyalgia, but basically for depression. Now, what type of depression? Like the prescribers, the psychiatrists, they usually look at, well, that's a diagnosis, and then look at what medications can you prescribe for that diagnosis, and what might be the best one that they've experienced. It might be because of the last pharma rep that just walked in, or it might be because they know that maybe you have anxiety and this one will work better for this or that. But generally, Cymbalta is, as an SNRI, is meant to stimulate you and also to maybe increase your chances of not committing suicide because you're more stimulated all at the same time. So to explain that, so norepinephrine, which is a component of an SNRI, is what helps you with your attention, with your focus, with being able to be very linear and to strategically get things done, right? Like you're on track. Serotonin, actually, so norepinephrine would be more associated with you feeling better about your station in life, right? Too much norepinephrine, you have anxiety. Too little, you're all over the map, and may not even be smiley type of happy. You might be like the character on I can't remember his name, but the blue donkey that was like always like sad, Anyway, that kind of like, I don't know if it's a good day, and like the serotonin aspect of that is very, like, serotonin is not an antidepressant. It doesn't make you happy. There's nothing happy about serotonin. Serotonin forms melatonin, which helps you sleep, and serotonin itself is an inhibitory neurochemical that keeps you from having ruminating thoughts that might actually be happening because of too much norepinephrine. So you have too much norepinephrine, you might have thoughts that you cannot make stop, and serotonin is an interruption for that. So in a real life example, it might be, did I shut off the stove? You don't really know or not, right? But the norepinephrine will be like, I need to go check that stove. Like, and then you actually call the house and somebody goes and checks it, and then you're like, God, do they really know how to check a stove? Like, there's no shut off for the mind that's just going around in a circle. So serotonin actually is the neurochemical that keeps people from committing suicide as easily, right? It's an anti-impulsivity neurochemical. So when you look at the spectrum of people that are being prescribed these antidepressants, right, you're looking at, are they a risk to themselves as far as like committing suicide? If so, then this is the serotonergic medications. Are they feeling flat and lethargic and haven't had any history of, suicidality or whatever? They just feel, and then this is the type of medication. And this is the hybrid of both, which in theory could be, an interesting proposition for the neurochemistry. But in many ways, you just don't get something for nothing. Most ways, most drugs are spending something. They're not creating it. And this one's spending both your serotonin and your norepinephrine. And when you find yourself bankrupt with both of those, it can be challenging, right? All right, next question. Is Cymbalta an anti-anxiety? Well, strangely enough, if it's prescribed for generalized anxiety disorder, then they're prescribing it for anxiety. However, this is not a great medication for most people for anxiety, right? I mean, you're too much norepinephrine means you have more anxiety. And giving somebody a medication that's raising, theoretically, your norepinephrine level is not usually what I would do. I mean, it's not something I would think of, right? Like, oh, let's just do some more of that. So I'm sure there's some studies out there that have been adapted, let's say, to show that it's good for anxiety. And I doubt that I doubt the researchers actually took the drug themselves. You know what I mean? Like I think that probably would have changed the outcome a little bit. But no, I don't think it's a great anti-anxiety medication. And it's Cymbalta and anti-anxiety. I will just say no. Next question: is Cymbalta a narcotic? No. A narcotic is just generally what you think of as narcotic. You think of a barbiturate, you think of a opioid, you think of something that's going to get you really, really, really stoned, and that the DEA said, heck no, that's illegal. So usually narcotics are not things you get from your prescriber, although sometimes the things you get from your prescriber, like Cymbalta, might be harder to get off of than a narcotic, but no, it's not a narcotic. Next question: does Cymbalta cause weight gain? Anytime I answer a question about weight, right, I'm always cautious to say, oh, and this will make you lose weight, because most people don't care what it is. If it was cat pee that was radioactive and you told them that it would lose weight on it, then here goes, cheers. So no, Cymbalta is not going to cause weight gain, usually most people. And then, the other portion of that is it's generally, it suppresses appetite. So, yeah. Next question: is Cymbalta a high-risk medication? In the realm of risk, no, it's not a high-risk medication. And I'm looking at my own personal scale. I'm not looking at anybody else's scale. I'm looking at the one that I've seen or felt or perceived over the course of my tenure working with people getting off psychiatric medication. And in my history of working with people, there's high-risk medication. That's going to be your antipsychotics. The ramification of taking antipsychotics long-term is by and large the highest consequence. Then you've got the benzodiazepines, and then you've got the opiates, right? Most people would thread this the other way around, right? But when you're getting people off this stuff, which one's the hardest to get people off? Antipsychotics, benzodiazepines, opiates, and then you've got down here is the antidepressant class. Now, I'm not wanting to in any way minimize the of how certain people have had this really, 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 really bad reactions to or getting off of antidepressants that supersede, like people in the chain. There is that class of people. For most people, to answer this question, it's the most people affected, the greatest number of people affected the most number of times. And it's going to be your antipsychotic class. For the antidepressants, in the class of antidepressants as a standalone, Cymbalta might be the worst, because there's nearly not a good way to get off of it. The manufacturer has made this medication like you're gonna take it whether you want to or not. You know what I mean? And I think there's another question I see here on the list that might address that. So, what is bad about Cymbalta? Well, it's bad in that the manufacturer has only made denominations of this medication that come in big jumps. Like most medications, there's a really, really small baby dose medication. You know what I mean? There's something that's small enough to where you can use that to taper down on, right? As a capsule. Like capsules, you can't cut them into little pieces because all the little pieces inside of the capsule fall out, right? Tablets, you can cut them and you can get a little smaller denominations and you can change the tapering rate. But with Cymbalta, that's more difficult. So you think, well, okay, let's take the capsule apart, let's count the beads. Well, some of those are inert beads and some of those are active beads. So even if you count the number of beads, right? So you get 100 beads and you want to take away 10, you don't know if it's 10 that are actually working or 10 that are not actually working, or a combination of both. That makes it confusing, right? And it just gets more and more messed up from there, right? So Cymbalta has that attribute to it, and I don't know, maybe it's the fillers or whatever the inert ingredients are that people seem to build up this reaction to. Like they're having a reaction to like they're getting red in the face and they're having like almost an allergic response to the medication, but then they try to get rid of the medication and have this whole other response of like having brain zaps and like this whole pathophysiology of things. It's like the catch-22, damned if you do, damned if you don't thing. This is sort of the script, if you will, the choir notes of somebody coming off of Cymbalta that I'm probably singing here. And so what's bad about Cymbalta is it's a capsule. The tapering back off of the same medication that you went on so easily may not be as easy or even possible to do as other medications such as Prozac. And it's also SNRI. I'm looking for another question here that might get to this point. So yeah, I'm going to answer more of that question later that I was going to address now. So let's go on to the next question. Who cannot take Cymbalta? I would not give aside from like who's old enough, who's not. I mean, all these medications, all these antidepressants have a black box warning that says do not give them to a child under 25 years of age because it will increase their chance of suicide. And you can bet it's not the drug manufacturers that just said, oh, let's put that on the box. It's because they were sued ridiculously over and over and over again and were mandated by a Food and Drug Administration that is largely like a fox watching a hen house anyway when it comes to these medication approvals. We're forced to put that on the medication. So there's that portion, right? And then there's just from a physiological standpoint, I mean, what's practical? Like you don't prescribe a stimulating antidepressant to someone who is already overstimulated, to someone who is anxious, to someone who is having the manic phase of bipolar as a thing that they've been dealing with in their life. People who have a schizoaffective or schizophrenic diagnosis. You don't give this to people that more dopamine and more norepinephrine is going to spin them out. And then there's the physical reasons, like it can increase glaucoma, things like that. I don't do internal medicine. I went to school to be a chiropractor, not even a psychiatrist, right? But like, there's this whole track of understanding physical medicine, right? That I could have learned if I'd have stuck with all that long enough. If I had a residential center that were dealing with physical problems for 18 years, I would have wrapped my head around it. But I've stayed away from internal medicine, and so when it comes to glaucoma and things like that, as far as like what this medication does, I'm usually not the right person to ask for that kind of thing. All right, next question. What organs does Cymbalta affect? Most medications are going to need to be cleared by the liver. So primarily, your liver enzymes are going to get involved in unpoisoning that foreign substance. And when I say unpoisoning, it's literal. It's literally your body is the process of creating the active medication, the active ingredient, if you will, is usually a process of metabolism inside the body that creates that actual chemical that they're trying to harness the effect of, whether it's with alcohol drinking, the aldehyde and ethanol thing, or it's been medication. It's like there's a metabolism that's happening, and it's happening in your liver. It's unpoisoning that so it can get rid of it, get it out of your body, turning it water soluble so you can get rid of it. So primarily the liver. Then the next downstream is going to be your kidney from that, but almost always your kidney and liver are involved in most medication clearing. And of course, Cymbalta is going to generally make people's heart rate go faster, and of course, it has effects on neurochemicals in the brain. So the brain, heart, kidney, liver are the organs that are, which basically means all of your organs, if you think about it, are affected by Cymbalta. Next question, is Cymbalta hard on your heart? Again, physical medicine, and especially long-term physical medicine, are not something that I have the expertise. And to find these kind of answers, you have to kind of go through PubMed and read and get, sort of informed about. So I did that, but only to a very light degree. And the things just knowing the medication, things it's going to do to your heart, it's going to make it go faster, right? So you're going to have this hypertensive like situation that is going to be tachycardia, they call it. And in the literature out there, what I found is that there was a meta-analysis of Cymbalta and cardiovascular things, and in these 14 different studies that they kind of highlighted the thing of, there were events of people having cardiovascular incidences, which involve stroke, myocardial infarctions, but is that typical with the medication? These are probably the outliers mainly that are having that sort of event. But in a very practical sense, how to answer this question would be like, if you're running the RPM faster on your engine, it's going to wear out your engine faster. It's just how it is, right? So it is probably revving up your heart, and it is challenging it, but it's not necessarily hard on your heart either. All right, next question is Cymbalta hard on the liver? I did not come up with anything that showed that Cymbalta is specifically hard on your liver. Hard on your liver? No. It's a poison. Your liver has to deal with it. But like hard on your liver, like high levels of Depakote or high levels of lithium carbonate is on your kidneys. No, I didn't see anything like that. I'm not saying it doesn't exist. I just didn't see anything like that in a cursory thing. But again, I don't do the internal medicine stuff. Next question. What are the brain zaps from Cymbalta? This one I think I know, right? So, how the nervous system works is basically you've got one nerve talking to another. Okay. Well, they're not actually talking to each other yet. In order for them to talk to each other, the resistance between this nerve and this nerve has to drop. The resistance, what they call millivolts, has to drop down for there to be depolarization to cause an effect at this nerve, right? So all the drugs are either increasing or decreasing the chance of that happening. So they're either putting a catcher's mitt on it so it doesn't happen, or they're going, you, come here. So when you're coming off of a drug like Cymbalta, you're coming off of a two-pronged drug. You're coming off of a norepinephrine drug, and you're coming off of a serotonin drug. So what's happening on a neurochemical level is probably the serotonin itself is the glove, right? And when you're dropping down the medication, right, you're losing that serotonergic effect, which is blocking the depolarization, right? And instead you're kind of still getting the norepinephrine effect. And this happens even if you don't have a norepinephrine drug. It's usually because of the serotonin drop. What I think is happening with the brain zaps is you're just having uncontrolled firings happening because the threshold to create them has gone from what would normally be here to there, and of course you're having brain zaps. Now, theoretically, they say that these things are not dangerous, but really, I don't think that's, you want to bet on that either, right? What usually helps alleviate that is taking some sort of, like bridging yourself over to Prozac. This is a good method. I know that some people are going to argue me on this, but if you can stop the serotonin plunge, you can handle the norepinephrine part of it, okay? You can, just because you don't feel like getting out of bed and all that, that's tolerable. The other part that I'm going to go commit suicide right now, or I'm having brain zaps, this is the realm of things that's like, whoa, let's not push that one. So flipping over to Prozac slowly, like taking half your Cymbalta and then half your target dose of Prozac, and then switching all the way over to Prozac, and or getting on half and half and then just reducing the amount of Cymbalta where you're still on the same level of Prozac and then dealing with the Prozac later can alleviate this phenomenon where you're having a serotonin plunge and get you on a medication like Prozac that has a 5-day half-life instead of, whatever the half-life on this is probably something around the realm of like 12 to 15 hours, and that gives you a better chance to be able to control the brain zaps. And that looks like that is the last question that we'll be doing today on Cymbalta. I hope that this information is, you find it valuable. Of course, you know, you guys with Cymbalta, what is that? I'm so embarrassed. I'm bad with names, but there's like Cymbalta Kills website, and there's like it's like you guys have your own army of people out there, right? And I know there's a lot of desperation around it. Just be very, very, very cautious with what you hear, whether it's from me or anyone else. You know, the people in your groups oftentimes are the quagmire of people that are, I've tried this and it nearly killed me, and that might be the thing that's actually good for you, you know? And because you've kind of concentrated all of the misfit toys in one spot, right? So, and then you feed off each other's fear and you say, okay, this happened to this person, and so that means it's not good for anybody, right? So there's that blowback, and then there's also like, you know, people like me, I've just witnessed what you guys go through and tried to figure out like what is the best way to help you, and then I've done it in a residential center, so I've come up with ways that actually seem to work pretty good, right? They don't always work for everybody, and I haven't had that authentic experience of having to come off this crap either. So just please gauge, like, you are the ultimate authority on you. Don't take anything I've told you as medical advice, because it's not. For one thing, this is just a peer-to-peer, you know, run these things by your prescriber, run this by your group of people that you trust, and come up with your own version of not just informed consent, but there's another term for it. Anyway, where you feel satisfied that you've had enough information for you to make a decision about you and not somebody else making that decision for you. Okay, again, have a good day or night, wherever it may be, and whatever time you may be listening to this, and hopefully we'll see you on the next video.
Thank you for watching. Don't forget to subscribe to our channel. For information about Alternative to Med Center, give us a call at 888-984-9667.